important.
Thank you, ma'am.
We are increasingly recognizing the importance of sleep. You know, as is commonly said, you know, 1/3 of the life you spend in sleep. But one never knew the advantage of having a good sleep for a health.
Yeah.
We know now number of diseases which are associated directly or indirectly, particularly neurodegenerative disorders. It's been dementia, Parkinson's, amyotrophic lateral sclerosis, and now even autoimmune encephalitis, some particular types.
Ma'am,
So-
we have not started. Ma'am, we are not started yet. Yeah.
No, I thought to introduce the little bit of the webinar.
Yeah.
Yeah.
Yes.
So this is what I think it's very important that, and you have an excellent speaker here, Manveer, whom I have known for many years. Yeah. And her daughter, of course, Avantika. I think it's a great combination. I think now the floor is for Dr. Matthew to go ahead and continue the proceedings.
Ma'am, we are not yet started. We got 5 more minutes to start. Yeah.
Oh, sorry. Then I will repeat it. Don't worry.
Sir and ma'am, Dr. Gauri Devi, good evening. Mansi here. Ma'am, we are still in the practice session.
Okay, sir. We'll repeat the same thing.
We still haven't opened it to the audience. So now that we are all prepared, should we open the rooms? So that people can trickle in one by one, and then we can begin in a couple of minutes.
That's a good idea, Mansi.
I think, Mansi, you have 5 more minutes, I think, by the correct time. Okay? So I think by that time, so more people will join.
Yes.
You can open it, I think.
Yes, okay. I have done that. Attendees. We will have attendees come in now.
Yeah. Okay.
Thank you. Yeah.
I actually thought you started the meeting.
No, ma'am. Sorry.
So you have to repeat the thing. Yeah. Okay. Dr. Matthew.
Yes, ma'am.
She is there. Vengamma is there, no? Vengamma is attending, no?
She must be attending, ma'am. Yeah.
We need more attendees now.
How many are there now?
There are 5. I'm just looking at the thing.
Yeah, they should be coming, ma'am. I think they
Yeah.
were attending the previous session, you know. It was
Yeah,
a
I attended that. Just now it finished a few minutes ago.
wonderful session, you know.
Yeah, whole session. I just finished that.
Are they on the same platform or on a different platform? Sometimes you can't make out.
No, it's a different platform. Different
platform. Different platform.
separate one.
I'm sure the XCOM members will be coming.
Yeah, I'm sure.
Vengama said she's there.
She'll be coming.
Okay. Okay, she's there. Good evening. Okay, fine. She has given in the chat.
Ma'am, I have just moved ma'am to the panel, so she will also be able to talk and start her video. Ma'am, Dr. Vengama Bhuma.
Can we start?
Yes, sir, you can start.
Yeah. Ma'am, can we start?
Yeah, sure. Go ahead.
Okay. Manasi, I'm going to share my screen.
Yes, sir, you could begin sharing. Automatically, mine will stop.
Sure. Good evening. We are now continuing from where we started before. We had a very emotional farewell for Professor Ashok Panagadia. And this is a topic which we have a topic which is intersecting.
Gender.
So it's the topic for today's webinar is a non-academic topic, and we thought for the scenario that we are in, we thought we'd choose a topic called intersecting role of personal and professional well-being in the COVID pandemic. And before I start introducing the topic, I invite our Grand Madam Professor Ma'am Gauri Devi, the renowned and mentor neurologist, to come in as the chairperson. Welcome, ma'am.
Thank you. Professor Matthew Alexander, Dr. Manveer Bhatia, Dr. Avantika, and Vengama, and all the attendees. I think this is a very important webinar, which is looking at a different aspect of neurology and neurosciences in respect to a well-being of the individual. We know that how all of us have been affected, both physically and emotionally, by the pandemic. And sleep is one of the victims of this whole situation. Many people have gone through insomnias, nightmares, and so on. And we also know that sleep has a very important role in neurological disorders, its presence or abnormalities in Parkinson's disease, dementias, hemorrhagic lateral sclerosis, and cardiovascular disease, and so on and so forth. So I think these two talks will enlighten us how to prevent or avoid them. I think I leave the floor to Dr. Matthew Alexander to go ahead.
Thank you, ma'am. So life before and at the time of pandemic. 16 months ago, we were traveling and totally oblivious of the pile of doom. A nearly invisible virus outbreak in Wuhan spread like a tsunami and consumed the world, changed the way we looked at life and everything we were proud of, humbled the human race, devastated the world with illness, morbidity, and mortality. And the services were bursting at the seams. And the caregivers needing to choose potentially treatable over the hill cases hit the psyche at the core. The caregiver fatigue, deaths, hopelessness, stress, deep recession, students not able to train, but some positives came in. Vaccine was made in the shortest time in the world, showed innovation, mRNA virus, AAV vaccines. People changed their lifestyles. Meetings became virtual. The world met on a virtual platform, telemedicine, and we are in for a new norm. And when I was discussing with my dear colleague, Dr. Manveer, whom I have great respect for, we were thinking what we should do for a webinar like this. And we came up with a topic which is very, very important in and I thought it's very important for the young fraternity to look after them. So we have two eminent speakers. Dr. Manveer Bhatia is a sleep guru, internationally known senior neurologist and sleep specialist, who's going to speak to us on sleep health and well-being. And then followed by Dr. Avantika Bhatia, who is a double MSc in clinical neurophysiology, clinical psychology and rehabilitation psychology, and as a PhD. She will speak to us on compassion satisfaction and compassion fatigue in the medical fraternity. And she's an assistant professor in psychology in Ashoka University. So we'll start and we'll take a few question and answer sessions. There are 20 minutes each of talks. And followed by that, it's very important to have a Q&A session. Over to you, Manveer. Question and answers can be put in the Q&A box. Over to you, Manveer.
Thank you, Dr. Matthew. Thank you, Dr. Gauri Devi and the organizers for giving me this opportunity to share some thoughts on the sleep health and well-being. I'm just going to the first part of the talk that I thought we would cover would be sleep health and well-being. And I think it's kind of befitting today that we are discussing this after the previous session, which we didn't really know it would happen, with an eminent neurologist who talked about spirituality, philosophy, well-being, and the overall picture of a human being rather than just a neurological disorder. And that's exactly part of the things that I'm going to be covering. So before we just dive into sleep health, just thought, what is sleep really? And what is the definition of sleep health? What do we know so far about this entity called sleep health? A relationship of sleep health with the overall health. Can we measure this sleep health? And I'll touch a little bit about the literature which is coming out now, the impact of COVID on this sleep health, and what we as a community, as what we can do as for policymakers, advocacy, etc. So sleep is this definition of sleep. It's a reversible behavior. It's a state of perceptual disengagement from and unresponsiveness to the environment. That was a traditional definition by Dr. Casten and Dr. Dement. I found another interesting definition which came up, which is a little bit more scientific and neurological. This is an emergent set of many physiological processes under primarily neurobiological regulation, and that impact many physiological systems. And that's exactly the concept of what is happening in the brain and in the body while we are sleeping, and what goes wrong if the sleep is not adequate. So another senior sleep person really said that this is a biological requirement. And in fact, he said it is a non-negotiable essential requirement. Just as we think of food, water, and air, we should think of sleep. So far, a lot of focus has been on sleep medicine. So there have been textbooks of sleep medicine. We have Bibles of sleep medicine, as they are called, the volumes which are written by the Rothkreider and Dement. But very little is touched on or touched upon the sleep health. And as we go a little forward, this was a really nice article, and I would encourage people who are interested to go a little deeper into this. Was published in the year 2014. It's by Dr. Daniel. He has done a lot of work on insomnia in any case. So he talks about the sleep health. And I have taken the first part of my talk from this article, which is talking about the sleep health. So he says that, can we define this sleep health? Can we measure it? And what is this importance? Overall concept being that sleep health indicates how well the individual is doing and also the population. I think that's a very, very big concept because so it's not just the individual itself. And I will show you now some more thoughts upon this, that why are we talking about this as a societal impact? Because whatever the individual faces as a consequence of this lack of sleep or poor sleep will impact the society. Because there's a thought and a concept growing that are we a more angry world right now because we are a sleep deprived world? Is the obesity growing because we are sleep deprived? I mean, you can say that this is from a very narrow perspective, but that's what the thoughts are. And if you look at the maps, the three-dimensional maps, they'll show that as the sleep duration is going down in the world, these obesity, anger, temperaments, emotional imbalance is increasing. So I think it's very important to understand that this is not the absence of disease. And that brings us to this WHO definition of health. And that was a state of complete physical, mental, social well-being. And it's not the absence of disease. So we don't talk about cardiovascular health being that you don't have a coronary artery disease. It's cardiovascular health. And I think I should have added brain health. So we don't talk about brain health, meaning that you don't have a stroke or Parkinson's disease. So it's a much bigger concept. And that is the concept or the word that what is sleep health. So this, Dr. Daniel went on to say that how the sleep health will impact the body functions and overall health. He talked about these dimensions of sleep, which are the satisfaction, the alertness during the day, the timing, the sleep efficiency, and sleep duration. They impact a couple of processes, which will again result in things like inflammation. You will keep hearing about the sympathetic nervous system activation, which is an imbalance of our sympathetic and parasympathetic systems, the hormonal responses, impact on the neural circuitry, and that will impact the health. So if the arrows go in this one direction, we do need to remember that the overall health and all of these impact sleep. So it's kind of like a circle which goes on, and to improve the sleep, we need to make sure health is good, and to get a good health, we need to ensure sleep is good. So these are some of the points that were made, that what are the dimensions. So when we talk about good sleep, what does one mean when we talk about good sleep? Simplest thing which comes to mind is the duration of sleep, is the number of hours that one sleeps. But more and more focus now is that we go away from duration and we come to things like continuity of sleep, the timing of sleep, for which we know this, the professors who got the Nobel Prize for the circadian rhythm, the alertness during the day, overall satisfaction and quality. Some people also talk about the depth of sleep, the regularity of sleep. So we have to have some quantifiable, some measurable dimension when we talk about things like sleep health. I'm going to skip these next few slides, but basically showing that every measure that we talked about, the dimension that we talked about, has been studied with a health outcome. And you will see the health outcomes range from cardiovascular diseases, diabetes, and even mortality. So all the dimensions that we mentioned, they have been studied extensively, the health outcomes being things like mortality, obesity, metabolic syndrome. So just to suffice to say that sleep, overall sleep health will definitely impact the all outcomes of the quality of life. And these are the domains which get affected with sleep. General health, and that's why this concept of health related quality of life, in many neurological disorders, we also do this HRQL. So it's just not being that, suppose, let's say for epilepsy, it's just not being that you don't have seizures. How are you as a person? How is your impact on your behavior, on your education, on your interpersonal relationships? So it's a huge burden that we need to carry forward to provide overall well-being. So sleep health thus got defined as a multidimensional pattern for sleep and wakefulness, and it is adapted to individuals' social and environment demands and promotes an overall physical and mental well-being. And the good sleep health is what we talked about, is all those dimensions need to be achieved. So they went on to say that, so how does one measure this? And they suggested this simple acronym. This is the S for satisfaction, A, alertness in the waking hours, T, the timing, E, the sleep efficiency, and D, the duration. And based on this, there was a scale. And all I can say is that in the last 1 year, I was looking at our data, I think the calls in for insomnia or poor sleep have jumped up by 50 to 60%. And so that's the kind of impact it's having. And if you look, I just found another article that the Google searches for sleep have gone up by 50 to 60%. The melatonin sales have gone up by almost 60 to 70%. So thus, these are the kind of impact that this pandemic has had, which we will discuss later. So the question often asked is, because the concept of duration came first, so how much sleep does one really need? This has been given by the consensus statement from the American Academy of Sleep Medicine, published in the year 2015, saying that adults should sleep 7 or more hours. And they've talked about the impact of short sleep and long sleep, that is less than 6 hours and more than 9 hours, will have adverse consequences on your metabolic, cardiovascular, neurocognitive profiles. So that was a simple thing to understand, was the duration. The second thing that we mentioned in sleep was the quality or the continuity. And that is that what are the stages that one goes through? Are you getting adequate amounts of the restorative sleep or the REM sleep? And of course, then the timing. And this was the circadian influence, that there is the central circadian pacemaker, which is in the brain, but we have small circadian clocks in all the important systems. Thus, if the circadian system goes haywire, the consequences will be felt in functions of all the systems. So what has happened over a period of time? What has happened in the society? It's been seen that in the last decades, a few decades, it's not recent, gradually the world is sleeping less and less. And it has been seen that there are some studies with the mortality that shorter sleep durations, longer sleep durations have adverse consequences. And this is what is called as a U-shaped curve. And most of the diseases have been linked like this. Why does it happen? I'm not going to go into the mechanisms. Is this a leptin-ghrelin problem, or is it a sympathetic overstimulation problem? So I'm going to come now to the last part, and which is the neurocognitive, and what Dr. Gauri Devi was mentioning. I'm going to skip the cardiovascular outcomes. Coming to the neurocognitive process. This is the most important thing, and that's called as the waste clearance. And there was a very interesting article also called The Nightlife in the Brain. And the scientist who discovered this whole system, which is called as the G lymphatic system, in the year 2013 was Dr. Maiken. She's in the University of Rochester, but also from Copenhagen. And she talks, and the last few 2-3 articles which I'm showing are just in the last 1 or 2 years. So way back in 2013, she discovered that there is a process that the brain cleans itself. And over the years, it has been more and more defined that what really happens at night in the brain. And this is the system called as the G lymphatic system. Why G lymphatic system? It's like the lymphatic system, but it's moderated or carried out by the glial cells. So she put a G. So this is from that article, and this is in the younger person, an elderly, but an Alzheimer's disease brain. So as the flow goes on from the arterial, and we know it has to come out from the venous side, usually this continuity and the flow is very smooth. These are the astrocytes, and they have the aquaporin 4 at their foot processes, and which moves all these little particles which are not needed, and they are all then taken out from the brain. In the elderly, this goes on the same way, but in a person with Alzheimer's, there is an impairment in these foot processes, impairment in the clearing and the cleaning, and you will get these plaques which are kind of become aggregates and lead to a degenerative process and dementia. So, okay, this is happening, but what's it got to do with the night? It's been seen clearly by the experiments that, and there are beautiful videos demonstrating that these perivascular spaces somehow open up to the tune of 50 to 60% at night. And there's like a flushing which happens. And this will happen only at night. This system is not activated in the day. So if we impair sleep because of any reason or the other way around, we do not look after our sleep, we are allowing these aggregates to clump together and lead to a memory process. And this is numerous articles of this is just published now in 2021, showing again the role of this in the implications for Alzheimer's. And similar things that, all these diagrams will show you that these are the astrocytes, the aquaporin 4 with very good CSF flow. When this aquaporin 4 is not functioning, these clumps start forming, and that is what leads to Alzheimer's disease. And this is the recent article again, which showed that the circadian control of this flow. So thus, just in a simplistic diagram, during sleep, the CSF goes in, metabolic waste is cleared. People have called it by numerous names. It's like a vacuum cleaning happening, dumping happening, whatever you may call. In the awake state, this is very minimal. So this sleep and brain health are very, very interrelated and intertwined. There are numerous articles now. So how to improve this G lymphatic system? Imagine if we were successful in clearing out all the garbage that we accumulate in the day. It should be cleaned out. And they say so far we have few things. Lifestyle things are exercise and good sleep, and avoiding a lot of other substances which can be harmful. So this is just to go in a very simplistic diagram. I drew this, that if this is poor sleep because of any reason, timings, gadgets, insomnia, anxiety, depression, you will have a decreased G lymphatic function, increased aggregates, and leading to a common path. This was called as a G lymphatic failure as a final common pathway. Just a few words about emotional health. We are talking a lot now today about emotional health. So there is a bi-directional relationship between mental health, emotional health, and sleep. What do we mean by that? We mean that if the emotional health or mental health is not good, sleep is disturbed. How common is this? To the tune of almost 50% to 75%. So patients with depression, anxiety, PTSD, schizophrenia, bipolar, they will have, large proportion will have sleep issues. In fact, now there is a thought that is sleep issue a precursor to these development of anxiety, depression. So that has to be kept in mind. This was a recent article which showed a very interesting, I'm going to switch gears to this emotion. So I'm going to talk a little bit about the amygdala. And it's fascinating to learn about the role of amygdala. So amygdala, we know, is like an emotional control. Anger, fear is all coming from there. And fortunately, now with this technologies like fMRI, it's been shown that people who have a good sleep, the amygdala sits in a very quiescent state. and it doesn't fire so much. But if the sleep is bad, the amygdala was seen to fire. And that's what causes this emotional reactivity, impulsivity, lack of proper emotional responsiveness. This was another study. This is showing that if you have similarly kind of thing, that if you have a restless REM, the amygdala adaptability is not happening. This is just a simplistic view that the prefrontal cortex and its role on the amygdala. So apparently it's like a brake for the amygdala. So, and when one is well rested, this influence is to the optimum, and you will not kind of start firing your amygdala, so your reactions are much less. But this gate control, or the brake as it were, is not adequate when sleep is deprived. So people can say that, I have patients who say that, I have changed, my irritability is much more. So could be that this amygdala is firing and sleep is not adequate. So this just to say that yes, sleep can affect your neurobehavioral function. Coming to the medical fraternity, numerous articles over the years have been about the impact of inadequate sleep on the residents in the casualty emergency, because you need very quick decision making, and that's why the rules came up about the number of hours of duty. And what has happened so far? So this was just again another article which has just come in the sleep medicine in the year 2020, and has found that the overall majority, 90%, reported poor sleep quality. And it goes on to talk about them that they have higher anxiety, they have depression, they have subjective fatigue, lack of concentration, etc. And this is with the GI problems, memory impairment. So thus, just sufficient to say that sleep quality among the residents in this population was poor, and it had a significant impact on their health. And this was another study that, so the use of hypnotics has gone very high in these people. And this was another study of the prevalence of burnout among the residents. And this was published in the year 2021, and again found. But what was sad was this study said that in spite of all or some measures taken, the prevalence of burnout has remained unchanged over the past 2 decades. So there is something that is missing and something that we are not picking up. I mean, we do hear about some younger colleagues, either they attempted suicides or depression. So something needs to be, or we need to have a low threshold to identify this population. This I'm just going to start winding up now, but a little broader concept. We talk a lot about the individual level. What is the belief? What is the behavior? In India, we have, co-sleeping. I've just seen a child, who's class 10, sleeping in between the parents, has had huge mental health issues, but things like that. So this is an individual society. Then it comes to where do we live? What are the socioeconomics, religion? And then there is public health policies, globalization, 24/7 society. So when we look at sleep or look at a problem of sleep health, we need to look at it in a very broad manner, and they have suggested, Dr. Gardner, as to how to then kind of modify these thoughts and how can we improve overall sleep health. Can we measure sleep health? I'm sharing a few. So we do know about sleep studies and all. I'm not talking about that. This is a interesting data which is coming up now with these sleep trackers. And this would not have been possible. So this is the Fitbit models. It was a systematic review and a meta-analysis, 25 million Fitbit users and 80 countries, 3,000 almost articles, 20 articles were selected. So, I mean, it's like huge amount of data that we can now study because of these sleep trackers. So there is an issue with these sleep trackers, but overall they tell you something about the total sleep time, wake after sleep onset, and it's been seen that, over a period what's changing. So American Academy then also gave out some statement on the sleep trackers, because patients are sending us data on sleep trackers, which they share with me on their phones or emails, and they're sharing with me for months on end that I don't think I get deep sleep, I don't think I get REM sleep. And what should scientists or what should physicians have to say about this? What about sleep in the pandemic? So yes, the numerous articles again have come forward. Changes in the sleep duration, timing. This has again been possible because of the sleep trackers from 6 major US cities, 163,000 Fitbit users again. And it was found that surprisingly, somehow the sleep duration has actually increased because people were allowed to sleep on their own times. But though the timings got shifted, but the duration got increased. So this kind of results are coming up. And this was like, again, another data, which was for app based. Again, you can see the number of nights, 8,000 users. This was a multiple countries were studied. And this is again to show that the sleep duration has increased. So just to conclude, sleep deprivation, poor sleep can affect all body parts, all systems, metabolic disorders, autonomic system activation, causing hypertension, cardiovascular. So what can we do, or what should be our role, or what has been done, let's say, in the past? So numerous guidelines in the West have come up about transport. Their truck drivers have to get tested. The federal aviation industry is very active on the sleep health because they know it causes fatigue, and fatigue can cause accidents. Medical guidelines have also been published. Number of hours of duty, number of hours that you can stay awake before you should be functioning in the casualties. The biggest thing happening now in the West is the school timings, and numerous states in US where the school timing has shifted for the grades like 9, 10, 11. It's been found that substance abuse is less, accidents are less, and children are happier, and cognitive performances are better. So these are the kind of policies that are available. What should we do? I think aim and role to recognize the importance of sleep health. We talk about lots of other aspects of health, food and nutrition, exercise, but we all need to kind of find a place for this because this is also the three-legged stool. If you were to look at, this is a very important leg. In fact, some say it is a balance, and over that, the other legs are standing off the stool. Make a lot of effort on public education. In addition to the interventions, this should also be considered. In fact, one study that I was looking at for the worldwide mortality, they said that behavioral changes, such kind of interventions, impact mortality much more than just availability of healthcare. So these are the things that one needs to look at if you want to look at overall well-being. Future, of course, would be things like, we don't have any biomarkers to say that, have you got good sleep? Have you not got good sleep? It's easy to understand that my cholesterol levels are high, sugar is high. This is going to be more a subjective thing so far. And that's where we'll need to go forward. And again, I think I want to end just by saying that I'm really thankful and grateful for having this opportunity to share with you. And every time that one gives a talk, one, I think, learns a lot more. So sleep health is a big thing that one should be aware of, and not only look at sleep disorders and sleep medicine and diagnose sleep disorders, but improve health overall. Thank you, Dr. Matthew and Dr. Gauridev.
Thank you, Dr. Manvir. Thank you, Dr. Manvir, for a very enlightening talk. Now we'll go to the questions and answer later. We now go on to compassion satisfaction and compassion fatigue in the medical fraternity by Dr. Avantika Bhatia. She's a psychology PhD. So over to you, Avantika.
Thank you so much. I'm just going to go ahead and share my screen. Okay, are you able to see my screen? I just want to make sure.
Yes.
Okay.
Yes.
Okay, so good evening, everyone. I'm very happy to be here today. As you have heard, I'm a psychologist by training. I work as an assistant professor of psychology at Ashoka University. I also have a clinical practice where I work with adult patients. My talk is going to be quite different, I think, from the medical sort of field. What I am really excited about and why I was thrilled to get the opportunity to talk today. Thank you, Dr. Alexander, for inviting me, is because I think it's so important to talk about mental health in communities where people are at risk and it's not being acknowledged as much, or people are not sort of being able to recognize some signs of what's happening. So that I'm excited to sort of talk about compassion in particular, compassion satisfaction, and compassion fatigue, because I think it's such a relevant sort of topic right now with the COVID-19 pandemic, and especially with given sort of the struggles that are being faced by doctors currently. Okay, so just as an outline, what I'm going to do today is I'll talk about sort of mental health in doctors, just sort of briefly summarize what we know. I'll then move on to talk about what we mean by compassion in clinical practice. And I'm sure these are terms that you all have heard, but I'll just tell you more about sort of the definitions and the research that we have so far. I'll then go on to talk about compassion fatigue. So I'll focus, of course, much more on this particular component, what the signs are of compassion fatigue, what are some risk factors, and then I'll end with talking about how we can sort of think about preventing, or if one is experiencing compassion fatigue, what we can do about that. Okay, so I said I'll sort of begin by talking about mental health in doctors, and I'm sure again this is maybe familiar to some of you, but what we do know from studies not just in India but across the world is that there is very high levels of mental distress that is reported among doctors, and this ranges from diagnosed mental illnesses to increased levels of distress. I know in the last presentation you had a few studies that Dr. Bhatia showed you about these levels and these increased levels, and that are really not changing. If anything, some of these disorders are known to sort of increase within the medical fraternity. And some common mental disorders that are noted are among doctors are depression, anxiety, and substance use. What is also very concerning is the high rates of suicide that are noted among medical students and among doctors. And, as psychologists or mental health workers, this is very concerning because, it really highlights how important it is to tend to mental health concerns and well-being concerns within this population, to make sure that we're not sort of losing lives this way. Now, I don't need to tell you, I'm sure, about the reasons that could contribute to the mental health professionals being at higher risk for mental illness or mental health concerns. As doctors, you face an enormous amount of sort of stressors in your work lives. And I know research has sort of documented this as long working hours, academic pressures. Some interesting ones are around sort of stigma around seeking support, how doctors always feel like they're the helping side, so it's very hard to actually seek help for oneself. And of course, lately sort of also facing grief, loss, being surrounded by patient stories of struggles. I mean, all of these we know can be pretty prominent sort of risk factors when it comes to mental health concerns. In literature also, some folks have suggested that it's helpful when we think about risk factors, because it can feel so overwhelming, that we divide them into sort of, the personal versus the contextual sort of risk factors. And personal factors can include things such as, one's personality, past experiences, and contextual factors are more sort of related to one's work environment and also what's sort of happening in their environment currently, right? So I wanted to mention sort of the contextual factors because I don't think we can talk about mental health today without talking about what's happening with the COVID-19 sort of pandemic. I mentioned the context because we find ourselves in this really sort of triggering environment, along with everything that the pandemic has got in terms of the physical sort of ailments. The WHO has pretty consistently been recording an increase in mental health concerns, which are tied into what the pandemic has sort of brought for us. And there are a number of sort of reasons for this. Of course, there's loss of loved ones, social isolation, feeling disconnected, again, feeling sort of increased pressure at work. And some of these concerns are even exacerbated if one already has had a history of previous mental health concerns. So we know anyway that the COVID-19 pandemic has had a huge impact on mental health. And for doctors now, this becomes almost like a double-edged sword, because you're not just dealing with all of these kind of impacts in your own lives, in your personal lives, but you're also dealing with this in terms of managing patient stress and patient trauma, right? So, it's not uncommon, of course, for medical doctors to have healthcare workers at this time to have experiences where they're really holding a lot of what their patients are going through. And this is sort of really what, made me feel like it's important to then talk about what happens when we are constantly hearing struggles or pain or things around sort of trauma from our patients, from your patients. I mean, how does that sort of go in, and what can one really do about it? I will also mention that, of course, we have research coming in this area. I've just mentioned one study here because this is sort of a study based in India, but there are studies across the world that are looking at healthcare workers and what's happening with mental health at this time. This particular study, I think, looked at around 3,000 doctors in Karnataka, and they did find that during the pandemic, 20 to 30% of doctors were reporting symptoms of anxiety disorders and depressive disorders. And certain populations were even more at risk, especially women or those who have had sort of mental health concerns previously. Okay, so I also wish, that we could talk about several areas of mental health and well-being, because there's so many, and I know we just had this talk about sleep. I also know that there was, the memorial today, so I know there's I'm sure people are carrying aspects of grief and loss. Because in the interest of time, we can't touch on all of these topics. I'll focus on the compassion piece in particular. Okay. So when we talk about sort of compassion in clinical practice, it's not sort of possible to talk about compassion without talking about empathy. So what do we mean when we talk about sort of compassion and relatedly empathy? So I'll begin with empathy first. There's several definitions of empathy. Neuroscientists also have, and it's an interesting area because it represents a lot of intersections between various areas of psychology and neuroscience, because there's been a lot of research done on empathy lately. One of the things that I've always sort of shared, which is empathy 101, that it's not sympathy. Like, it's not something that you're doing to pity the other person. What empathy really means, or common understanding of empathy, is that it's our ability to understand another person's feelings and thoughts, while also understanding that it's about the other person, it's not about us. So, for example, if you're sitting with somebody and you're hearing about sort of a loss that they've experienced of, say, a parent, and you feel really the sense of sadness that comes with loss, or the sense of despair that comes with loss, it's feeling that, but and also recognizing that these are not your feelings of sadness and despair. It's about what the patient is bringing in. So that would be a definition of empathy. Another way of thinking about it is, as I've mentioned here, it's feeling with others. This is different from compassion, which involves a component of empathy. So there is empathic concern. There's a feeling of warmth towards the person that you're working with, towards the patient. But there's something else there. There's also a need to want to help the other person, get out of the suffering that they're in. And that sort of means more compassion. With empathy, that pro-social sort of behavior where we want to help the person is not necessarily there. Neuroscientists have also sort of distinguished between different sort of parts of the brain that are getting activated with empathy versus compassion. And they've identified or termed empathy as the socio-affective path, more related to like the feelings, and compassion as the socio-cognitive path, which also has a component of thinking and wanting to do something about what one is feeling. Okay, so I think it must be pretty clear that, empathy as well as compassion are pretty integral components of any helping related work. And this includes, of course, working with patients. And there is research that points to how empathy and compassion in clinical practice is related to health-related outcomes, patient-reported outcomes, treatment outcomes, patient-clinician relationships. But, so there's all of this. There's the work piece, where that's why empathy and compassion is really important. But there's another piece. It also helps or is known to relate to clinician well-being. So clinicians who are able to sort of say that we are feeling empathic in our work, we do feel compassion or high levels of compassion or compassion satisfaction, we feel satisfied with where we are and how we are sort of tending to our patients, they also report better well-being, right? So this is why sort of this becomes really important across helping professions, but and within the medical fraternity especially. Okay, so I wanted to bring in here what healthy compassion and empathy look like in clinical practice. And again, I'm hoping that you will be able to relate to some of this in what you do, and maybe you might be able to see some things that you don't do that might be helpful to look at. So there are three sort of components here where we think about, okay, this is compassion and empathy happening in a very healthy manner when we're working with patients. The first is taking on the other's perspective. So this, literally sort of means entering the other person's world, entering the other person's sort of shoes, seeing where they're coming from, seeing what their life experiences are, understanding the context. I mean, I know that there's no sort of diagnosis made without sort of looking at some of these things. So really being able to sort of sit with that, allowing oneself to sort of feel what they're feeling for their patients, whether that's frustration, anger, feeling close to somebody, feeling connected with somebody, disconnected, whatever it may be, but really understanding what the other person is sort of feeling in the room. The next is self-awareness. And this is sort of the distinction between, okay, so I know that this is mine and this is the other person. So for example, if I'm working with somebody and I've had a really sort of exhausting day and I'm, feeling frustrated with them, that I'm able to understand, okay, that's my frustration. It's got nothing to do with what the patient is like or what the patient is bringing in. Or again, if I'm, sitting with the patient and I'm feeling really, and this happens sometimes in working with people who are pretty severely depressed, like one also starts feeling quite depressed. So that may be good because you're able to understand what the person is really feeling, but you're able to understand, okay, that this is not mine, this is not my feeling, this is what the patient is bringing in. So this distinction between what's mine and what's theirs. And the third is emotional regulation. And this, I think, is a really important piece also. I work with some medical doctors who come in and talk about really feeling very overwhelmed with what their clients are bringing in. And again, I think this is so relevant sort of in the context that we are in today, where doctors are sort of being, really sort of in a position where they're hearing more and more about sort of suffering and pain. And there are a number of ways in which emotional regulation can work. So good emotional regulation would mean that even if you get overwhelmed in the moment, that you're able to sort of find ways to say, I'm okay. You can ground yourself, get out of that state, versus, emotional regulations that can move on to places that are not as healthy. One can get really overwhelmed. One may not know what to say to the patient, may make the wrong diagnosis, may not be able to form a treatment plan. And in some cases may just check out, like may just not be able to listen to what the person is bringing in, what the patient is saying, may find themselves distracted, and so on. Okay, so this also sort of takes us to our concept of compassion fatigue. So what happens when we don't have these healthy ways of being empathic or compassionate sort of in clinical practice? So one of the things that we can think about is compassion fatigue. And compassion fatigue is a concept that's been around since the mid-90s, and there's been a lot of research done on this particular area in a range of helping professions. So medical doctors, ICU workers, nursing staff, mental health professionals. So we have data from like these various groups of people or different populations. And essentially the definition is that it's the negative consequence of helping. So some people also talk about it as the cost of caring for others. And what we find, what happens here is that one feels very emotionally and physically kind of exhausted as a result of hearing about other people's suffering. And this concept was first defined by Figley, who was working with war veterans, and found that he, as he was hearing stories of trauma, of war trauma, that he himself felt like something was changing for him where he was getting very wrapped up in the trauma and was not able to really separate out or the effects of what the other person was feeling, was carrying some of the effects himself. So I also want to distinguish here that compassion fatigue is different from burnout. So I know that we had a study in the last presentation that talked about burnout, which is important. It's related to compassion fatigue. It can come up as a result of compassion fatigue. But in literature, burnout means that it's a response to job-related stressors. So the idea is that if one changes their job or work environment, the burnout can reduce, right? Like you take away the work-related stress, you feel better. But one can't really reduce compassion fatigue because you really sort of carry that because it's related to the trauma of what somebody's sharing with you, the suffering that somebody's sharing with you. Burnout doesn't necessarily involve trauma. It doesn't have to involve trauma. Compassion fatigue has also, like I said, been studied in many different ways. One of the very common measures that is used is the professional quality of life that was developed by STAM. It's available online. It actually gives you a sense of where you are with your compassion fatigue, compassion satisfaction, and also burnout. And, again, I want to mention that with compassion fatigue in healthcare workers has been examined, with medical professionals has been examined. I've just mentioned 2 studies here, but there are actually quite a few. I'm happy to sort of share them later if anyone is interested. One of these was conducted in Spain during the pandemic, and they found that the levels of compassion fatigue and satisfaction reported compassion fatigue reported were quite high for the medical fraternity. And even in India, there have been studies that have looked at, doctors experiencing or reporting a lot of symptoms of compassion fatigue. Okay, so let me come with that to what some of the signs of compassion fatigue. I'll mention here that compassion fatigue is not a disorder. It's more like a cluster of sort of symptoms, or you can think of them as experiences. But one needs to watch for these because it can go into an area that could, resemble secondary traumatic sort of disorders or secondary traumatic stress. As I mentioned earlier, it can have an impact not just on your work, like as the work that you're doing, but also on your own sort of mental health. So it's definitely an area that sort of needs tending to and needs attention. And some of the signs of compassion fatigue include anger, irritability, tension, difficulty in empathizing with others, finding sort of very low stress tolerance, especially as compared to what your stress tolerance to be, suddenly feeling like you're not able to sort of take even a small amount of stress that you were able to manage before, feeling a low sense of accomplishment in one's work, difficulty in concentrating, and of course, sleep issues. As Dr. Bhatia mentioned, many of these things are bidirectional, and sleep is absolutely an indicator, of signs of compassion fatigue. Related to sleep, nightmares and flashbacks. So this, and especially nightmares and flashbacks that pertain to what one has heard. So this again is a sign that if one is really sort of getting very invested in their patient's stories and feeling very empathic or compassionate at the time, but is not able to then sort of move away from that, right, in a healthy manner, is not able to sort of set that boundary of coming home and, keeping sort of the clinical work away, which I know can be really hard to do. But if it's really seeping into sort of, sleep and nightmares and resulting in flashbacks, that could be a sign of compassion fatigue. Feeling isolated, I think compassion fatigue can be really hard to talk about because who does one have, right, to talk about? If you're listening to sort of people all day talk about sort of their suffering, and I'm sure you felt this as medical doctors, that, where do you go at the end of the day? Who do you talk to? And do you want to talk about it after a point? Maybe it just feels too much. So you hold things in, which ultimately is also not very helpful because then it leads to other problems such as these. Guilt and self-blame, feeling like one is not doing enough. So again, part of compassion is wanting to help the other person. But I know very often we're not able to help others in the way that we want to. And holding some guilt from that or blaming oneself could also be a sign of compassion fatigue. Okay, so I'll move on to talk about risk factors and vulnerable groups. So again, it can be helpful here to think about contextual factors as well as personal factors. Some of the things that we know is that people with fewer years of experience are more likely to experience compassion fatigue. And there are a number of sort of reasons for this. One reasoning is that psychiatric disorders do tend to develop sort of in early adulthood, many of the psychiatric disorders. So maybe this particular group is sort of more vulnerable. Maybe they're facing more stressors, than the ones who've already been in clinical practice. Maybe they have sort of less support, as you can see further down the list. Gender, women tend to experience more compassion fatigue. This should also not be too surprising, because I think women are socialized, in any sort of context, to care for others, to really help others, to be more empathic. And, we can expect some of this to also come up in a working relationship, where one is constantly hearing sort of about suffering and pain that can really sort of take a toll on how that's being processed. People who are parts of some minority groups or identify as parts of minority groups are more at risk. Those who've already had past exposure to trauma, are working in poor sort of working conditions, where they're not feeling supported. These are some of the contextual factors that could lead to compassion fatigue. And with personal factors, there are also a few here. So there could be a past history of mental health concerns. So we do know that those who've already had mental health concerns in the past then are more likely to experience compassion fatigue. Past experiences of helping. Now, I think this is really interesting, and this sometimes gets missed. So I'll just spend a minute talking about this here. So this would mean, if we ask doctors, people who've chosen sort of the medical line, why have you become, the question that one would ask sort of kids, like, what made you want to become a doctor? And quite commonly, like one of the common sort of responses amongst most doctors would be to help others. And as a psychologist, I find it really interesting, because if you think about helping and this identity of wanting to help actually begins way before one even decides to become a doctor. That maybe there's something in one's family where one has been used to taking the helping role, or one has seen the helping role being taken by others, but there's something there where the person has already got a history of helping. So now if we think about it, if somebody has had a history of helping, which has not been very healthy, right? Like say, as a young child, one is sort of helping sort of mediate parent fights or family fights, or mediate, other things that are happening within the family at an age that's not appropriate. So, we can imagine then that by the time the person comes into a professional role of helping others, they're carrying some of that with them. That, the helping is so important that they don't really know when to take a step back or when to set a boundary for themselves. And that can really sort of permeate into this experience of feeling compassion fatigue. I hope that makes sense, but I'm again happy to answer questions if I went too fast with that. And that is also linked to this idea of difficulty with boundaries. People who are not able to sort of set these boundaries, which are so important with helping related work, where one can say that I'm going to do everything that I can for my patients, for the people that I want to help. But when I need to take that time for myself and set that boundary, but I won't carry that into my daily life. That can again sort of contribute to increased levels of compassion fatigue. And then finally, difficulties with emotional regulation. So it might be that there are people who generally have a hard time with regulating emotions. Maybe they've had experiences of loss themselves or grief themselves. It can be really overwhelming. They've had, experiences themselves of illnesses in the family, and they have a certain way of managing their own anxiety, which is not very healthy, right? So if there's already that sort of pattern that's set in place, we expect, and that would also come up in a clinical practice situation that can impact the person. Okay, so I think with that, I'll just end with bringing things together and what can we do. I think as a psychologist, like one of the first things we always talk about to people is that notice the signs. I think compassion fatigue and this idea of compassion is so interesting because very often we work on autopilot and we don't always pause to see what's happening in these domains. So if I think it's a big win if we can have doctors just sort of pause and see how they're feeling, as a result of their work, see how connected they're feeling with their patients, how much are they carrying into their own lives. So just sort of creating some awareness around that would be the first step. Other things that we know, in fact, again, I've not mentioned sort of the studies here, but I'm happy to share them later, that there have been sort of studies in the neuroscience field on compassion training and brain plasticity to see how one can actually train themselves to be more compassionate. There have been some interesting experiments done by psychologists that have indicated that it is possible. It's not something that is very rigid, that one can make an effort and actually improve on these areas. And some of the areas, that one can improve on is self-care. So I know it's like a big buzzword now in mental health about talking about self-care. I like to think about self-care as, what parts of yourself are you taking care of? And maybe sometimes it's the academic part that needs to be taken care of. Maybe sometimes it's doing sort of webinars because that's self-care, feeling like you're connecting with other people outside of patients. Maybe it's, spending time with your family, or if you're a parent, being more connected to that role, but really making sure that all parts of your identity are getting some time, in your week, in your schedules. Finding ways to regulate one's emotions. If you're recognizing that some emotions are really sort of difficult for you, or you get really caught up in like anger or stress or sadness, finding ways to sort of regulate them. I know mindfulness is one of the ways in which one can do that, but of course the other ways also. Practicing self-compassion. So a really interesting thought is also that we can only be compassionate towards others if we are compassionate to ourselves. And there have been, again, some training and offered and modules offered. Kristen Neff is a really big sort of person in the field of self-compassion. And she has multiple sort of ways in which one can work in being more compassionate towards oneself, which will ultimately sort of help in being compassionate towards others. Okay, so I think, with that, I can end. I'm happy to sort of stop here and take any questions if there are. And again, I really, want to thank Dr. Alexander for the opportunity. I know that this was slightly different than a typical, talk in the neuro field, but I was excited to be here today. Thank you.
Thank you, Dr. Avantika, for a very enlightening talk. I think it's really amazing to look. I think it's a very, listening to both of you, I think it's given us a different perspective. We really don't have much time, but I think there is Dr. Arthur Ray from the UK, who's asking Dr. Manveer on daytime naps and studies on that. Does it have REM, any REM patterns? And do you have any experience, Dr. Manveer, to talk about, when we have power naps, when I have busy, we have power naps.
So this the word nap and this power nap kind of came together. There have been lots of studies on this, but I'll just put it briefly that the timing of the nap, that means where in the day are you taking the nap? So if you take it after 3:34 p.m., it's known that it will cut the sleep drive and interfere with your night sleep. Second is the duration of the nap. So these power naps are meant to be a nap and not meant to be a siesta, like not a few hours. So 10 minutes, 15 minutes. Why do we say that? Because when you go into stage 2 and wake up, you will feel bright and rested and refreshed. But if you go into stage 3 and come out of it, you'll be very groggy. So that's the kind of purpose. Yes, they work well. They are like a miniature kind of a power nap, as they are called, in short.
Thank you, Manveer. Dr. Avantika, I just want to ask you about, as a psychologist, how do you advise on work-life balance? And there is a lot of thing of compassion. It's very difficult to compartmentalize. When I see a lot of intensivists, I see a lot of them in that, they're like mercenaries all the time, and they're a little different from the rest of the people. So I just wonder, how would you advise on work-life balance, and what about faith? The role of faith in how do you look at compassion, the satisfaction and compassion fatigue? How do you look at it from that perspective? Because we are from the Indian, side, apart from the Western world.
Yeah, and I wish there was more time to sort of touch on some of these things in my talk, but there have been really interesting findings on certain cultures and how compassion fatigue and satisfaction are dealt with. And the idea is that within more sort of collectivist communities, that there will be greater levels of compassion, that we're already sort of attuned to understanding other people's pain and suffering in a way that's quite different. I talked about sort of women doing that, but I think that also stands true in communities where we are very geared in or tuned into how other people are feeling. I think the idea sort of with, working just sort of a lot, or like really sort of being in that position where we're taking in a lot of clients, I think one has to ultimately sort of step back and see how it's impacting oneself. So these are not sort of clear, rules that you shouldn't do this or you shouldn't do that. It's more about what is the impact that it's having on you. And so the idea with compassion fatigue is that sometimes we are so caught up in wanting to help others and we're so empathic that it can almost start taking a toll. I will also say that neuroscientists actually don't like the word compassion fatigue. They call it empathic distress, because they feel compassion is not the problem. It's the empathy and, really sitting with high levels of empathy, and that is the problem. So there is a little bit of controversy within sort of fields, or, a little bit of a tension there, that some neuroscientists are saying that we shouldn't really use the word compassion fatigue. We should call it empathic distress instead.
Sorry, you're finished, Avantika? Manveer, I have one comment. Being used to that consciousness project, etc., at NIMHANS, there was a concept of yoga nidra. Yoga nidra is not the duration of the sleep. It is like, it's a deep sleep. At the same time, you're little awake. So there they used to say even 3 hours of yoga nidra is quite good. First point. Second is, today's youngsters, they have different circadian rhythms. They sleep at 2 a.m. and get up at 12 noon. What happens to their sleep cycles? You might have studied. These two are the important.
So, yes, there is a lot of research in our country about this yoga nidra. So that's why, because this whole concept of are they asleep or are they awake? And some people who practice the yoga nidra, actually then they say that your requirement for the sleep duration or the sleep need gets less.
Yes.
So that's definitely, I agree with you. Coming to the second point, yes, not even 2 a.m., ma'am. People are sleeping at 4 a.m., 5 a.m. They add 8 hours and then they wake up in the afternoon. So with this, the circadian clock. So in fact, there is now this concept that there are 3 clocks. One is the sun clock, one is the body clock, and one is a social clock. So ideally, the body clock is in sync, or supposed to be in sync with the sun clock, because, or why is it essential? That there is a time period of all these hormones, how they peak and they trough. So melatonin being one of them. So melatonin is not only for sleep. It has an influence of lots of other body functions. The cortisol levels, when they peak early morning, they go down at night, they also have a purpose. The sympathetic stimulation, the growth hormone, which is not only just, so it's a repair hormone which has to peak at night. The TSH has to peak at that particular time. So if we keep the screens on, or if we push this whole cycle forward, we are actually creating a misalignment with all these hormonal endocrine process. So these children, students, youngsters will face the impact over a period of time. So they will have, I have seen a lot of them now in this time, which is well known even in the literature. The impact on, so they don't have major big health problems. That's why they're not really cognizant of the fact these days. But they have emotional health issues. They have a lot of emotional imbalance. Their reactivity is much more. So in fact, people say this teenagers, as we say are teenagers, they are very short-tempered or irritable or reactive. Is it because this whole sleep cycle has gone haywire? So it will have an impact on their brain health, emotional health, and then have an impact on their physical health in the time to come.
The third clock is, you said one is sun
Social
clock and then
social clock, which is
social clock.
new
Okay.
clock. It's a new concept. So the social clock is totally at loggerheads with the other body clocks.
Okay. Right. Thank you. Very nice.
Manvi, what about, what do you see the prevalence of sleep apnea? And it's very under-recognized. People go to the cardiologist and they really don't even look whether the guy has bad OSA, you know. As a sleep precision, how much do you think is being under-recognized in the
Worldwide data says 80% of men and 90% of women. And the current data which came out, I think just a year ago, that 1 billion in the world have OSA and 500 million are moderate to severe. In our country alone, we'll have at least 20 to 30 million. So what's happening is, you're right, that guidelines are coming out. So if you look at the cardiology guidelines, for hypertension, they say that if you are requiring more than 2 medications, think about ask for snoring and obesity. For diabetes, I just had a talk a few days ago on the diabetes for relationship. They have guidelines. In fact, there's an Indian Diabetes Association which has given guidelines. Atrial fibrillation has very strong guidelines that please check. In fact, now there are some guidelines for stroke, that OSA to be checked as a risk factor. Dementia, should we start looking about things about sleep? So it's coming in many disorders. I think the basic thing is that how much of sleep is covered in undergrad or in postgrad.
Yes.
So I feel that's what happened to US. I mean, they found that it's not being covered. So they kind of have gone back and started introducing it as a concept that, like you're reading other disorders, at least read on how to ask 2-3 questions. And, then it will impact. And I was just thinking in this pandemic that I have seen the patients, like Avantika was mentioning. So some of our patients don't fit into these disorders. Like I can't call them an insomnia by definition. I can't call them, a circadian disorder by definition, but there is something that's going wrong with their sleep. So where do we fit them? We don't know. So it's a big, so I think we need more people to take this up as an agenda, that this is important, and we need to kind of create a noise about it in other specialties.
Manvi, there's also a question. Do we have a sleep subsection? This is again from Dr. Ray. He's from the UK. Do we have a sleep subsection?
So this was suggested a few years ago. I've forgotten who the IN president was that time. So, I mean, we talked about it, and, how to create a subsection.
Yes.
So I did put forward, I think I kind of took the step and I came back. So we can look at it again. Okay. Now that we have more people interested, and I think there's a certain requirement as to the number of people who need to submit it. I was also thinking once that should it be, we can discuss this later, as part of a clinical neurophysiology subsection, because it will become like a separate entity, it's
specialty.
Yeah, and then you need that many members, and there are so many subsections. So
it could be part of it.
I think, Matthew, that's a good suggestion to be put it as a part of clinical neurophysiology. After all, even this webinar is part of clinical neurophysiology subsection.
Medicine,
so why not include this? I think that's a good suggestion.
And people who are getting it, as a clinical neurophysiologist, those are the people who will get into sleep.
I think it's a good idea. We can think about it. Yes, Matthew?
Yeah. Thank you. I must tell the group that Dr. Avantika Bhatia is a worthy daughter of Dr. Manvi Bhatia. I'm very proud to have the next generation share our Indian Academy screen. Welcome, Avantika.
Thank you.
Thank you.
I just want to say this before.
Thank you.
I discussed some of things I think she doesn't know, but I think this being overwhelmed and the distinction between empathy and compassion and compassion fatigue. I think we all go through it, but only thing is we don't recognize it. I have a tendency to kind of absorb the patient's story too much. So then, it is, and I can say that maybe when I hear especially the women's stories, what they're going through, there is a bias, let's say, that, you kind of absorb those stories and they're very, very sad. Especially with the field that we are in, that I'm in insomnia. It's very overpowering to listen to these stories. So I think it's hard to sometimes, like you're saying, to form that distinction, unless you really learn how to form that distinction.
Avantika, what's the cost of compassion?
Compassion, this is the cost, compassion fatigue. One says that it's the cost of caring, and the reason why I gravitate towards these areas, because there's no black or white. There's not like you should be this level of compassionate or you should be low levels of compassionate. I think the idea is very much that most people enter into helping professions because they want to help others, and then they get caught up in it sometimes when it takes a toll on your own mental health. So that's where we really need to kind of watch for that happening.
So some kind of a detachment with attachment, yeah.
Right.
Some kind of what Bhagavad Gita says, you do your job, but try to be a little, detached. I know it's very hard to do that, but that may be with the attempt, I guess. I'm not sure.
I think I agree that the mental health, one of the risk factors she mentioned, that
yes,
mental health, because in any case, people don't seek help. And I think doctors kind of feel that, this is something that I can handle, and I don't think I should ask for help.
Asking for help. That's a very important.
That I think we should encourage the younger colleagues and senior mentors, that if you find that somebody, as I say, is dipping, please step in and take help.
Your line is getting broken, Manvir, in between.
Oh, okay.
You're interrupted. When I was at Nimhan's, in view of the couple of suicides, we started having a counseling for the resident. And we said a fixed time you go to that particular psychiatrist. Nobody went there because then they would be stigmatized. So then we canceled that order, but just told verbally, so and so is available at any time. You see, that is very important because nobody wants to be said, oh, I am mentally weak or I've got depression. Nobody wants to accept that, isn't it? Huh? Avantika, you would agree that nobody wants to say,
Yeah, I think there's a question here on, if one should have sort of regular assessments to see empathy levels. And actually my response was going to be this, that it's not so much the assessments, but maybe creating more of a support system within a program or a training program. My own training program, when I did my PhD in psychology, we had a lot of that built in. And I think that's what allowed us to be good clinicians, especially within the field of psychology, because if we didn't have that support, we would not be able to listen to our clients.
Absolutely.
Yeah, I completely agree.
Yeah, very important.
So I think we had a very good session, and I think I must thank Dr. Manvir and Dr. Avantika Bhatia for a fantastic 2 lectures. I think this is really not in the regular same, but I think we should have more of such talks in the future. Thank you, ma'am. I think we can continue. The question answers we can actually message on the chat. We can do it on the online system. I think we are already reaching the time. So thank you so much. Have a good evening.
Matthew, can we ask Vengamma about the conference thing? You said she would announce it now, or
can we? Because only 30 people are there, ma'am. Can we send a mail?
No, but you only mentioned that at the end of the webinar, maybe we just give an opportunity.
Yes.
To say.
Dr. Vengamma?
Vengamma?
Vengamma, are you there?
She's there.
Yeah, I'm there.
Yeah. Yes, Vengamma. Just say a few words, then later on it can be circulated also.
No, basically, actually, we thought of organizing somewhere in the month of September or August. But now looking at the peak and then now whatever the predictions for the 3rd wave, I thought it may be difficult to organize this year. I thought it is a better suggestion to postpone to 2022, maybe the better. Because here actually, though the 2nd wave is little receding, but we have lot of this mucormycosis, lot of work. And again, the predictions for the 3rd wave are there in 6 to 8 weeks. That's what today's paper and the team's director were telling. I thought it may not be possible for me to organize this area with my backup, all the administrative responsibilities. I was just thinking if it is something 2022, I'm willing to do somewhere in January or February, whatever the dates. Meantime, we can organize. But it's going to be virtual. I don't think it can be physical. It's going to be virtual. Even if it comes down, I think things may settle. It will take another 1 year, I think it looks as of now. That's what I was just discussing, wanted to discuss with Dr. Matthew and others. Like, this year may be difficult. This is what my suggestion.
I think, Dr. Vangam, I think we can plan for August next year. January might be too, with all these things happening. I think we will just postpone it by a year. I think anyhow,
Okay.
these are unprecedented times. So I think all of us understand that that's precisely why we're choosing the topics, and we can already have some more webinars and all that. So I think it's fair enough. I think everybody will understand that. Is it okay, ma'am?
Yes, I think perfect. I think all of us would agree for that, because even January, February is not going to be
too early. Yeah, make it August.
Next August, and that's when we will.
Sure, ma'am. Definitely.
Thank you, Dr. Vangamma.
Thank you.
Dr. Manasir, and thank you, Dr. Avantika Bhatia. Have a good day.
Thank you, everyone. Thank you.
Thank you, Dr. Manasi, for all the help that you gave.
Thank you. Yes.
Thank you. Thank you, Manveer. Thank you, Avantika. Thank you, Thomas.
Bye.
Okay.
By then you'll be back, Matthew?
By November I'm back in Bello.
No, by next conference you are there back.
I'll be there to help you.
Okay, thank you. Oh, you are coming this November. Okay.
November to Bello. Yeah. Thank you.
Okay, sure.
Bye.
Okay, thank you all. I think we
Thank you
now, Matthew.
Yes, ma'am. Thank you very much, ma'am. God bless you.
Thank you.
Thank you, Academy.
Thank you.
Have a good evening. Stay safe and stay healthy.